Okay, next are dealing directly with sleep disturbances. Anything that we do, psychotherapy or with drugs, is going to be like spitting into the wind or trying to roll a ball up a hill if there are ongoing unaddressed sleep disturbances. And this is an example of poor sleep here, so you can recognize that. Sleep is the most critical factor in regulating normal brain functioning, okay, cognitively, emotionally, and so forth. and yet, despite its tremendous importance, it's very, very fragile. And so almost any kind of distress can result in some type of sleep disturbance. And so this is kind of a first order of business, is really addressing this. And this is, of course, after you deal with life-threatening issues like homicide or suicide or issues like the hospitalization. This has got to really be up on the front burner because sometimes you get very inadequate responses to medication because this issue has never been addressed. Okay? All right. Now, the insomnias of depression and anxiety, acute psychosis, anxiety disorders, situational stress, typically presenting with initial insomnia. Once you go to sleep, you stay asleep. Depression, of course, the problem here is staying asleep. People may or may not have trouble going to sleep, but they have trouble staying asleep. They wake up a lot during the night, or they wake up at 4 in the morning and they can't go back to sleep. Now, I want to talk about one version of anxiety-related early morning awakening, and this is for people that are under incredible stress or they have generalized anxiety disorders. And I mean, I can certainly relate to this. It's happened to me, and probably for many of you as well. And maybe there's just a lot going on, and so you may have trouble going to sleep. You go to sleep, but you wake up not because it's something endogenously happening, like happens with depression, but it's because something wakes you up. A dog barks, or something like it. Something wakes you up, and immediately your mind goes into full gear. Okay, and you just start thinking about all this junk, all the stuff you worry about. Now that's really different than a classic early morning awakening with depression, where people, they may or may not wake up and think about stuff, but what they'll do is they'll wake up, and even if there's nothing on their mind, they're just wide awake and they can't go back to sleep. A lot of this has to do with high cortisol levels, not allowing people to get in and stay in deep sleep, for instance. Okay, so anyway, those are, all of you I know this kind of stuff, but I just wanted to highlight that. Also, hypersomnia with depression. It occurs in about 15% of people that walk in our doors with major depression, and here is the take-home point, and that is 4 out of 5 people that have depression accompanied by hypersomnia have bipolar 2 disorder. Bipolar 2. Not 100%, but 80%. They're give or take a few percent. So when this particular classic symptom of sleeping way too much is the big red flag of possible bipolar disorder. Now, bipolar is much easier to diagnose if you have full-blown manias, obviously. Okay, bipolar 2 is tougher to diagnose. Also, in kids, the first 1 or 2 episodes of bipolar disorder are depression before you have any hint of mania. You go to DSM. Bipolar disorder is based on a diagnosis is based on presence of a major depression and a period of either mania or hypomania. But look, 70% of kids have had no mania. And how about with teenagers and adults? 60% of their first episodes are depression. And typically they'll have 2 depressive episodes before they have any sign of mania. So you go sniffing around for a history of mania and you may not have it. So that means we're going to have to look at other things to try to make the determination about is this a bipolar. Excuse me a moment. And as you may know, and we'll get to details later, you give antidepressants to people with bipolar, and 2 things are going to happen. Either it's not going to work, it's going to make things worse. So this is we'll get to the details of that, but this is a big deal. It really is. Okay. Now, those of you that have taken my neurobiology class know this. I'm going to review this very briefly, okay? But these are the stages of sleep during the night. There's rapid eye movement sleep, REM sleep, and then there's non-REM sleep. And the critical thing I want to focus on are stages 3 and 4, which contain the majority of slow wave sleep. This is also referred to oftentimes as deep sleep or restorative sleep. And any disruption of sleep architecture can cause problems, but the most common and the most problematic is not getting enough deep sleep. All right? And anxiety and depression in general reduce the amount of time spent in deep sleep. And it's not because you're worried or what you're thinking about. It has to do with the lingering presence of higher levels of cortisol, and then the other molecule that we talked about very briefly is CRF. Both of those really interfere with deep sleep. So the disorders themselves, especially depression with high cortisol levels, anxiety can have high CRF levels, can interfere with this. Slow wave sleep is important for several functions. One is just to restore a person so you have energy the next day and you're not feeling tired. If you are deprived of deep sleep, studies going back 20 years or more show that the next day the immune system is not operating optimally. There's a significant drop in certain white blood cells if you don't get enough deep sleep. That's why when your mom, you get the flu or something, and your mom says you need to go sleep, there's really something to that. Deep sleep activates part of the immune response. The release of growth hormone occurs, about 90% of it occurs during slow wave sleep. And for adults, this is absolutely critical for maintaining the skeletal system. And when you have decreased availability of growth hormone, it sets the stage for much greater likelihood of developing osteoporosis. I mentioned this before. In depression, osteoporosis is twice as likely to occur than in people that don't have depression. And it's directly due to decreased slow wave sleep and the decreased release of growth hormone. But beyond those things, which are important, are this. And really, there's no exception. All human beings, if they're deprived enough of slow wave sleep, are going to get tired during the day, they're going to have cognitive problems, mainly trouble staying focused, paying attention, and affect dysregulation. And for normal volunteers, the affect regulation problems are increased irritability and lower frustration tolerance. People just get impatient, or get irritated easily. But for people with major psychiatric disorders, this can pull the rug out from under them. And the group that is the most vulnerable to being negatively affected by decreased slow wave sleep are people with bipolar disorder. Sleep deprivation, either insomnia or not getting enough slow wave sleep, is poison for people with bipolar. Okay? I'm going to skip over those. With depression, one of the reasons you get very little slow wave sleep has to do with if you're in that group of 60% of people who are depressed have hypercortisolemia. Here's what you get normally. At nighttime, cortisol levels are 0, which is important because it interferes with deep sleep. An hour or an hour and a half before you wake up, cortisol levels start rising, and again they're at their peak around 7 a.m. Of course, it depends on if you're keeping a regular schedule. If you're a shift worker, then you have to factor that in. But people that sleep during the night, work during the day, very high in the morning, goes down at night. But people that have hypercortisolemia, it's going to fluctuate a little bit. It's going to be basically high and continuous through the day, and severely interfering with the capacity to go into deep sleep. All right. I also want to mention that there's another very common problem we see clinically that results in severe impairment of deep sleep, and that's chronic pain. The people have chronic pain for whatever reason, arthritis or you name it. When they turn at night, the pain knocks them out of slow wave sleep. And this is a very big deal. A lot of the depression that you see with chronic pain is directly tied to chronic sleep deprivation. So that's a common issue. Okay, so what can you do to enhance slow wave sleep? before I talk about this, I want to tell you, this is just my own opinion, take it or leave it, but I think this is a discussion to have with a patient and their family, and this is almost regardless of the diagnosis. But let's use depression as an example. Okay, once you're clear about the diagnosis, you've gotten history from the patient and from their significant other, you develop your early warning list and that sort of thing, then I think it's again important to get the family or the partner involved and say, now look, here are the things I'm going to recommend in terms of treatment. And you talk to them about their options, but it's okay to highlight what you feel like is probably in their best interest, okay? For some people, you might say medications might be helpful, although I think in your case psychotherapy would be better, but it's an option, okay? But I think that the conversation to have goes like this and saying, listen, and this is for major psychiatric problems, not situational stress, okay? If somebody has bipolar or major depression, is we cannot waste time. We need to dive in here and pull out all the stops and target this on several different levels. Because the truth is that depression or bipolar or whatever you want to call it, this kind of disorder is challenging and does not respond immediately to treatment, and the best outcomes clearly come when you approach this from several perspectives. And then you can map out things like the role of exercise, with mood disorders, especially the family, keeping the person engaged in the world is a high yield intervention. They stop going to church, they stop going out to eat dinner. No, you've got to make an effort to stay out in the world and engaged, okay? Good dietary habits, talk about sleep issues, medication if that's indicated in psychotherapy, and just say our best shot at getting you out of this terrible depression is if we do all of the above. And because this is depression we're talking about, I know it, you do too. This is going to be really hard to do entirely on your own, and that's where I want to bring in your family to help. Okay? I think that just get writing a prescription or just doing psychotherapy, oftentimes it's not enough. It's not enough. Okay, so getting back to this, I want people to understand a little bit about the importance of getting good sleep, all right? And this can involve a 5-minute little discussion about their sleep and then talk about the importance of slow wave sleep. You can use the term deep sleep if you want to. But here's the thing to do. Okay, regular exercise. Now, aside from using exercise as a treatment for anxiety or a treatment for depression, here we're talking about exercise as a way to enhance quality sleep. And this is not a quick fix. Exercise, probably the most doable version of this is 10 minutes of exercise twice a day. Most people that have significant psychiatric problems are very disinclined to go 3 times a week to the gym and put in 45 minutes. The research shows that that can be effective, but you got to be realistic about this. So it's much more likely that a person, especially say guy's depressed, and you get his wife involved, he says, okay, now Mr. Smith, you have a coach, and here she is right here. And she's going to help you get off the couch on Saturdays and Sundays and go with you and walk for 5 minutes, turn around and walk back. Okay? And otherwise, it ain't going to happen. Not with depression. Almost never, unless you engage the family. Okay? So, regular exercise, and typically after about 2 months, human beings in general are going to start spending more time in slow wave sleep. Now, again, I'm not talking about treating depression because it can do that too. But the goal here is to increase the amount of time spent in slow wave sleep. This is especially important in the elderly that are getting a lot less slow wave sleep than younger people. Okay, this should not occur 2 to 3 hours before bedtime, because just exercising jacks up some stress hormones, may make it difficult to go to sleep. Okay, sleeping cool. This is a big deal because sleeping cool allows you to go into slow wave sleep. And there's 2 big problems here. Problem number 1 is that people, when they go to bed, want to be nice and cozy and warm, especially in the wintertime. Electric blankets or a bunch of blankets on the bed, it feels really nice and good and you can go to sleep. But the problem is that if your body temperature body doesn't cool off, you won't get in slow wave sleep as much. So what you do is find out what their practice is. Tell me about how you sleep. Tell me what your bed situation's like. If they have an electric blanket, good. Turn it on, get that bed nice and toasty, then shut it off, crawl in bed, crack the window, and sleep at 66 degrees or 68 degrees with a light blanket on top. This is going to get you more slow wave sleep. Okay? Or don't sleep with as many blankets. The other big problem has to do with women going into menopause. And I see some heads shaking like, okay, now you're talking. I'm there. Part about perimenopause is the body temperature, core body temperature doesn't cool off as much. And a lot of the chronic fatigue and some irritability that you get around the time women are moving into menopause probably has a lot to do with chronic low-grade sleep deprivation because they're not getting enough slow wave sleep. Okay? Melatonin can be used because the primary effect of melatonin is to lower body temperature. That's what it does naturally. It gets released at nighttime by the pineal gland, and people sometimes will use melatonin, high doses of melatonin, as a sleeping pill, but that's really not the way to use melatonin. Melatonin is designed by nature to gradually cool the body down. And so the dosing on this is considered to be safe is 1/2 milligram at 6 o'clock in the evening. And you got to tell patients, if you recommend this, that they will feel absolutely nothing. It won't make them feel tired. And I know this is maybe a stereotype, but I think Americans want a quick fix. They want to feel something. I get a headache. I want to take some aspirin and half an hour later have it start going away. Or if I can't sleep, I want to take a drug and 30 minutes later I'm asleep. You have to explain to them that we're using really tiny doses, but it's closer to what happens naturally in the nervous system. And what melatonin really does is to help you get better quality sleep. And so you're not going to feel sleepier, you won't go to sleep more easily, but the likelihood is within 6 or 8 weeks you're actually going to start noticing you have more energy during the daytime. Okay? And then avoid substances that interfere with slow wave sleep. The worst of all is alcohol. Alcohol absolutely destroys sleep. And benzodiazepines, the tranquilizers, also can interfere with slow wave sleep. Now, the problem with this is that people under stress may have trouble going to sleep. They maybe have an anxiety disorder, they have high situational stress, they have depression, and they can't go to sleep sometimes. And so you drink 6 beers or take a bunch of Halcyon or Ambien or something, or 3 milligrams of Xanax, it'll knock you out. And so people's subjective experience is, yeah, but this helps me sleep. And, well, it helps you go to sleep. Okay? But when people are taking alcohol especially, and I'll talk to you about how much in just a minute, and a number of the tranquilizers, it can't, if a dose is high enough, it'll knock you out. But the price that's paid is what the sleep folks call decreased sleep efficiency, and it means there are more awakenings during the night, and there's less time spent in deep sleep. Okay, and this includes most. Well, I would say most. I need to change this to a number of prescription sleeping pills. Now, among the sleeping pills that are less likely to cause this are Sonata and Ambien, and probably the reason for this is because they have a very short half-life. The half-life of Sonata, and half-life is the amount of time it takes for the blood levels to drop by 50%. The half-life of Sonata is 30 minutes. It's kind of the ideal sleeping pill in a way because it gets in and it knocks somebody out and then gets out of your body. Because most people don't go into their first episode of slow wave sleep until they're asleep for about an hour and a half, and then they start going into slow wave sleep. So the problem, I haven't seen the research on this, but you may have seen Ambien, controlled release Ambien, gives you a second dose middle of the night. Seen that? I'd like to see the impact on sleep stages when you're getting a middle of the night dose. I don't know what it is, but typically these have a relatively minimal negative impact on sleep stages. This is a relatively new drug. It's been out for 2 years, Lunesta. And the drug company research shows it doesn't interfere with sleep stages. The drug company research. Okay, so we'll see. We'll see. Rosarum activates melatonin receptors, and it doesn't interfere with slow wave sleep. It may actually enhance that. Okay. Now, this is just a little bit of trivia. I've heard that 90% of what people learn in a day-long class, 90% of it is forgotten within 3 hours after the class is over. Okay. Now, my guess is that the trivia that I tell you throughout this class will be the main things you remember. Okay. So here's a little bit of Lunesta trivia, and that is a third of people that take Lunesta notice that they have this kind of unusual, somewhat unpleasant taste in their mouth that tastes like tuna fish. Isn't that weird? I don't know why. If you like tuna fish, I guess it's okay. But if it's working for them, but they don't like the taste, then I recommend, this is not practice guidelines, this is my own personal recommendation, 2 or 3 times a day, a teaspoon of mayonnaise. And no, I'm just joking, Okay. Okay, now we're going to get really specific here, okay? And we're moving close to being finished for today. Non-habit forming alternatives. Okay, trazodone. Now this is if you're on a game show and they ask you what is the top-selling prescription medicine for sleep in the United States? The answer is trazodone. Okay, it's been used for many years. Trazodone is not a tranquilizer, it's an antidepressant. It happens to be a lousy antidepressant. Doesn't work. You have to use huge doses that would put an elephant to sleep. But it's become very popular as a sleeping aid. Okay, and you can see the doses are somewhere between 25 and 75 milligrams at night. Doesn't interfere with deep sleep. It knocks people out. It's not habit forming. It sounds pretty good. Now, here's the one very significant downside of trazodone. All right, one of its side effects is it causes orthostatic hypotension, and this is where we've all experienced this at time to time, where you stand up real quickly and you get lightheaded. Okay, and in some people it's very pronounced. Now, where this is a real problem is in people over the age of 60, especially women, but men as well, because the skeletal system starts becoming more fragile. Somebody takes trazodone. Men and women alike, after the age of 60, have to go to the bathroom more at night. And so they go to sleep. 3 hours later, they wake up, they got to go to the bathroom. They get up too quickly, get lightheaded, and fall. And then you've got a hip fracture, which is catastrophe, really, for people. So that doesn't mean you don't use trazodone, but what it means is that you tell people, anybody, but especially older folks, that if you get up too quickly, you can get dizzy and may pass out. So what you do is sit up on the side of your bed and wait about 30 seconds or so, and then hold on to something and gradually stand up, and then when you feel perfectly steady, then you can walk to the bathroom. Okay? Well, when I went to visit my mom, she was taking all that Benadryl. She was recovering from hip fracture. Guess what her doctor was giving her for sleep? Trazodone. Didn't work well enough, so she started adding Benadryl and Tylenol PM. She was going to sleep, but she'd get up in the night to go pee. Guess what? This woman's recovering from a hip fracture. For God's sakes, give her trazodone? Give me a break. Not her a break. You give me a break. Okay. God. Okay, so she got on Remeron after I talked to her primary care, and her primary care doctor was totally cool with all this. I mean, he was a really, oh, okay, yeah, you're right. Okay, now Remeron is an antidepressant, and at low doses, it's very sedating. It also can cause weight gain. That's the downside for a lot of people. But in elders, 7.5 milligrams, and for teenagers and adults, 15 milligrams. It knocks people on their butts. It's not habit forming. at these doses, it's probably not high enough to really treat depression, but it can help them sleep. Okay, so it does not have orthostatic hypotension, and my mom got on that and did great. Tricyclic antidepressants. There's a lot of we'll look next class at antidepressants that treat chronic pain, and they actually do a pretty good job of that. The best really are some of the really old tricyclic antidepressants, and in fact the one that's the best is Elavil. Now Elavil came out in the 1960s, and it's got tons of side effects. It has a lot of anticholinergic effects, okay, but used in very, very tiny doses, it can do two things. One is it can put you to sleep, and the other is it can oftentimes significantly reduce pain. And unlike opiates, like codeine and Vicodin and so forth, is not habit forming. So we're looking at doses between 10 and maybe 75 milligrams, typically given at nighttime. Can help people go to sleep, but if the part of their sleep problem is also chronic pain, then that may address that. I want to just mention briefly that my sister has relatively severe chronic pain from a spinal cord injury, and her life is just a mess, and she's depressed and in pain a lot, and she got a sleep study, and she's had two of them actually, and the most recent one was about maybe 3 or 4 months ago, and she slept in the sleep lab, and they measured brainwave activity. And she actually, sometimes people have trouble sleeping in a sleep lab. You have to stay for a couple of nights before you actually kind of get used to wearing, the electrodes on your head and that kind of stuff. But she slept, and she slept 8 hours, and then they woke her up. And then they asked her, do you remember waking up at all during the nighttime? And she said, no, I don't remember. I think I slept through the entire night. Well, guess what? 0 time in slow wave sleep, and 183 awakenings during the night. Now, the awakenings being defined as either waking up completely or going into stage 1, which is twilight sleep. Okay? And when people are having this kind of awakenings and they get virtually no slow wave sleep, oftentimes they don't remember waking up. But guess what? How they feel the next day? They're really tired, really tired. And with chronic pain, if this happens over a period of weeks, which it always does, okay, their pain threshold gets lower, and they hurt more during the day. So there's some real benefits in treating with a drug like Elavil to help improve sleep and control pain. And they're much likely to get better quality sleep. Okay, now this one, there's some differences of opinion here about the use of Seroquel. Seroquel was originally approved by FDA for treating psychosis. It's an antipsychotic. It does other things as well. And even on very low doses, like 25 milligrams, if you take Seroquel, most people, it'll just knock you on your butt. It's very sedating. But many people, after a few days, will adapt to that low dose, and so if they're going to use it on a regular basis for sleep, it's often in the 1 to 200 milligram range. And this is in people that don't have any psychosis at all. It's a relatively effective sleep medicine. Okay. Also, it's one of the few drugs in psychiatry. It not only causes sedation, but it actually increases slow wave sleep. So that looks good. Okay. The problem is that antipsychotics have a bunch of potentially very problematic side effects that we'll get into in a later class. So the people I know, psychiatrists I know, say that should be low on the list. Okay, but it's being used a lot. It's being used a lot in nursing homes too, because not only does it help people sleep, it also shuts them up. Shuts them down. Behavioral control. All right. I'm not advocating that at all, but Benadryl, we've talked about that. Occasional use of Benadryl is totally okay. It's not a problem. But it's got lots of anticholinergic effects, so if you use it on a regular basis, it may interfere with your memory, it may cause constipation. In older people, it can actually cause a delirium. People look psychotic because they're taking Benadryl. Okay, melatonin, we already talked about melatonin. And the final thing is caffeine. And I know many of you have heard my caffeine story here, so bear with me. But we're going to talk about this, and then we're going to stop for the day. Now, I must tell you, I had to go upstairs and get a Coke at the break because I am exhausted. So let me abuse drugs here. All right. Whoops. Caffeine interferes with the ability to go into deep sleep. That's the main take-home point. It may or may not cause problems falling asleep, but the main problem is that if you have even modest amounts still in your bloodstream when you go to bed at night, it's hard to get into deep sleep. And especially that first episode of deep sleep, which occurs about an hour and a half after you go to bed. And in your separate packet, handout packet, right after the quick reference sheet, I think, yes, caffeine questionnaire. I think this should be mandatory for every single person if they've got schizophrenia, bipolar, or they're having, situational stress. We should get a caffeine, a current reading of their caffeine intake, and it's very straightforward. And if you've never used this with your clients and you start doing it, it will just knock you over. People, of course not everybody, but many people really jack up their caffeine levels when they're depressed, especially, but also if they're under stress. Now, caffeine makes anxiety worse, so it sounds counterintuitive. If you have, situational anxiety, or you've got an anxiety disorder like panic disorder, why in the world would you use caffeine? But there's two reasons that it gets used a lot when people are under stress. One is it combats fatigue. So people that are stressed out are not sleeping. They're exhausted. Anxiety wears them out. Okay, they're not they don't get restorative sleep. And even though it throws gas on the anxiety fire, they use caffeine for the same reason a lot of us do, and that is to stay awake. Yes, you can work or drive or go to school or what have you. The other thing is that caffeine has some noticeable but very transient antidepressant effects. So I'm not depressed, thank goodness, at least not right now, but if I drink a cup of coffee, I'll notice I'm more alert. But if I had really severe depression and I drank a cup of coffee, the likelihood is I would actually very quickly feel somewhat less depressed. And that probably lasts for about 15 or 20 minutes, and then I kind of slide back into depression. And human beings, whether they do it consciously or not, almost always are just going to kind of lean in the direction of things that reduce suffering. And it's just not unusual to find people who are depressed that are, drinking 8 cups of coffee a day or something like that, not realizing that the big price they pay is it kicks the legs out from under them in terms of quality sleep. So the amount of caffeine, guess what the caffeine level for anxiety disorders, what's the amount that you should take? 0, okay, because it clearly increases anxiety. With depression, probably the best guideline is to not exceed 250 milligrams and only ingest it before noon. And that gives you plenty of time for the caffeine to work its way out of your system at that level. Now, again, this is a little bit of trivia, but it's important. There's a drug called Luvox. It's an antidepressant, but it's used mostly, it's FDA approved for treating OCD. The normal half-life of caffeine is 3 hours, okay, in adults. It's about twice that in elders, okay. 3 hours, I drink a cup of coffee, 3 hours later my blood levels of caffeine drop in half, 3 hours later that's cut in half, 3 hours later that's cut in half, and eventually by the time I go to bed, just a little bit in there. Luvox has an impact on the enzyme that metabolizes caffeine, okay, it inhibits that, and it changes the half-life of caffeine from 3 hours to 31 hours. So if you just have 1 cup of coffee every day, over a period of time, you're going to get a progressive buildup of caffeine. And that's just an example of how drug interactions can really be problematic. Okay, Let's take a look at this slide, and then we shall stop. Restless legs, primary sleep disorder. Now, there's restless legs where people feel jittery and they move their legs around. There's a related condition called, I don't have it on a chart up here, but nocturnal myoclonus, and it's where people jerk, you know. And a lot of people do this occasionally. You'll be in bed with somebody and they'll jerk, like it wake you up, or maybe you do it yourself. Okay, wake yourself up. And there is restless legs syndrome, which is a primary sleep disorder, okay? And so it can be a primary disorder, but also this is something very interesting. And there's not good epidemiology on this, so it's hard to know how often this happens. But it can be caused by antidepressants. But usually not right off the bat. Usually after you've been on antidepressants for a few months. So what you'll see clinically is a person, let's say that they happen to be on the right medicine, right dose, and they're getting better. Okay, and then they start not getting so better. And they're reporting more daytime fatigue and breakthrough depressive symptoms. Again, there's a laundry list of things you can look at to say, okay, why are we getting breakthrough symptoms? One of those may be restless legs. And what happens is, now I'm going to give you the details of this, and we'll come back and talk about this phenomenon next time we get together as well. But that is the antidepressants, all of them except Wellbutrin, increase availability of serotonin. One consequence, okay, is that since serotonin is inhibitory through most of the brain, it starts shutting down the dopamine system in subtle ways. That's what's responsible for the affective blunting, okay? And that's what's responsible for the restless legs. The drugs that they use to treat restless legs increase dopamine. Okay? I think I've got those here. Yeah. These are the FDA-approved drugs for treating restless leg syndrome, okay? Or you could reduce the dose of the antidepressant, and if that continues to be okay for the person, they don't relapse, that can be helpful. Or going back here, you can add Wellbutrin to the mix, or if they happen to be taking Wellbutrin, they're not likely to get it because Wellbutrin increases dopamine rather than blunting that. Lots of people with restless legs do not know they have it. Okay, and so that's why asking the spouse, have you noticed a change in your wife sleeping at night? Is she more restless? Is she moving around? Is she jerking a lot more? Is she snoring? Is another thing we'll talk about next time, is getting information about that, because it could be that when you get restless legs, oftentimes you start spending less time in slow wave sleep. You're kind of flipping around and jerking around so much. So that is one reason you start getting what looks like loss of efficacy with the antidepressant.